Every morning in parks across China, a practice so common it has no formal name. Adults over 60 rising onto their toes and dropping onto their heels. 30 times. The practice has no name that translates cleanly into English. It is simply what you do in the morning. The way brushing your teeth is what you do. The way boiling water for tea is what you do. It is not discussed as exercise. It is not taught in a class. It is not marketed as a wellness protocol. It is passed from generation to generation as something the body needs. Not questioned, not explained, just done. The grandmother does it. The grandfather does it. The park fills with people rising and dropping, the sound of heels striking ground carrying across the morning air like a slow collective heartbeat. Western medicine has spent decades developing pharmaceutical interventions for the conditions this practice addresses. Bisphosphonates for osteoporosis, compression stockings for venous insufficiency, manual lymphatic drainage for edema, balance training programs for fall prevention. The Chinese practice addresses all four in 60 seconds with no equipment and no prescription. The practice is not folk medicine in the sense of unverified tradition. It is folk engineering, an empirically discovered mechanical intervention that activates 6 physiological systems simultaneously through the physics of impact. The impact each drop produces sends a mechanical shock wave through the calcaneus, the tibia, the femur, the pelvis, and every vertebra in the spine at approximately 30 meters per second. The shock wave reaches the skull within a fraction of a second, and the shock wave is not damage. It is the signal. The only signal your skeleton recognizes as a reason to build. Your bones are piezoelectric materials. When mechanical stress deforms bone tissue, compression, tension, or shear, the hydroxyapatite crystals embedded in the bone's mineral matrix generate a small electrical charge. Piezoelectricity, the production of electricity from mechanical pressure, is a property of the crystal structure itself, the way quartz produces a voltage when squeezed. Your bones contain hydroxyapatite crystals arranged in a collagen matrix, and when the matrix deforms under load, the crystals generate a charge that is measurable, consistent, and directional. The charge is strongest along the axis of maximum compression. It is weakest where the bone receives no load. The electrical field the charge produces is the signal. Osteocytes, the mechanosensory cells embedded throughout the bone matrix, connected to each other by a network of cellular processes running through the bone like wiring through a wall, detect impact through multiple pathways simultaneously. They are the most abundant cell type in bone. Approximately 25,000 per cubic millimeter, and each one sits in a tiny lacuna connected to its neighbors by thread-like extensions called canaliculi. Bone mechanotransduction operates through at least 3 signals: piezoelectric charge generation in the crystals, fluid shear stress as interstitial fluid is forced through the canalicular network by the deformation, and direct cellular deformation of the osteocyte itself. The piezoelectric component is the most physically intuitive. Pressure generates charge, charge directs building. Current research suggests the fluid flow through the canalicular network may be the dominant mechanosensory pathway. The impact of a heel drop generates all 3 signals simultaneously. The osteocyte detects the combined input and transduces it into a biological response, chemical signals to osteoblasts, the bone-building cells, directing them to deposit new mineral matrix along the lines of maximum stress. This is Wolff's law operating at the electrical level. The law, the dirt-walking discussion described as mechanical remodeling, revealed here as an electrochemical process. The bone does not merely respond to force, it reads force as an electrical pattern and builds along that pattern. Where the charge is strongest, the bone thickens. Where the charge is absent, the bone thins. Where no signal arrives, in the bone of a person who sits all day, who walks only on flat indoor surfaces, who never produces the impact that generates the charge, the osteoclasts continue their normal activity of disassembling bone to reclaim mineral, but the osteoblasts receive no signal to rebuild. The balance shifts toward net loss. The bone thins not because of disease, but because the electrical signal that directs its construction has stopped arriving. The skeleton is not a fixed structure. It is an electrically responsive architecture that remodels itself continuously based on the mechanical signals it receives. Every gram of mineral in your bones was deposited because a mechanical signal told an osteoblast to deposit it there. Every gram lost was lost because the signal stopped. Think about what a single heel drop does to this system. A single drop, rising onto the toes and allowing gravity to bring the heel sharply back to the ground, generates a vertical compressive wave that passes through every bone in the axial skeleton simultaneously. Calcaneus, tibia, femoral neck, lumbar vertebrae, thoracic vertebrae. Cervical vertebrae. Cervical vertebrae. Every bone along the vertical axis receives the mechanical signal in a single impact. The combined piezoelectric charge, fluid shear, and cellular deformation arriving at every osteocyte along the line of force within milliseconds. No other daily movement loads the entire vertical axis with a single compressive pulse. Walking loads bones cyclically but at low impact. The heel strike during normal walking produces approximately 1 to 1.5 times body weight of force distributed across the gait cycle. Running produces 2 to 3 times body weight but is inaccessible to most adults over 65. The cardiovascular demand, the joint stress, the fall risk make it impractical for the audience that needs the signal most. The heel drop delivers the impact loading of running, approximately 2 to 3 times body weight, concentrated through the heel strike. Without the joint stress of forward locomotion, without the cardiovascular demand of sustained running, and without the fall risk of moving at speed. The person stands in place. Gravity provides the force. The skeleton receives the signal. Now, the NASA connection. Because the fastest rate of bone loss ever documented in healthy humans occurs not in bedridden patients, not in the elderly, but in astronauts. And the mechanism that produces it is identical to the mechanism operating in the person who sits all day. Astronauts in microgravity lose approximately 1 to 2% of bone mineral density per month, 10 to 20 times the rate of age-related bone loss on Earth. The rate varies by skeletal site. Weight-bearing bones like the femoral neck and lumbar vertebrae lose at the higher end of this range, non-weight-bearing bones less. The mechanism is the absence of gravitational loading. Without the compressive force of body weight passing through the skeleton, with each step, each stance, each impact, the mechanical signal ceases. Osteoblast activity decreases because no impact signal is directing mineral deposition. Osteoclast activity, the cells that disassemble bone to reclaim its mineral content, continues unchanged, because osteoclast activity is driven by metabolic demand, not by mechanical signal. The balance shifts toward net bone loss. The skeleton thins. The astronaut returns to Earth with bones that have aged years in months. Parallel to the sedentary person over 65 is not metaphorical, it is mechanistic. The astronaut loses bone because gravity is absent. The sedentary person loses bone because the impacts that transmit gravity through the skeleton are absent. The osteocytes cannot distinguish between zero gravity and zero impact. Both produce zero mechanical signal. Both result in osteoblast inactivity. Both produce net bone loss, the osteoclast continuing to disassemble bone while the osteoblast receive no signal to rebuild. The astronaut's loss is faster because the signal is completely absent. No standing, no walking, no weight bearing of any kind. The sedentary person's loss is slower because some low-level signal persists from standing and walking. But the high-impact signal that drives the strongest osteoblast response is missing. That parallel, the astronaut's bone loss from absent gravity and the sedentary person's bone loss from absent impact, producing identical osteocyte silence through identical physics, is the parallel that made the bone density conversation about physics rather than pharmacology for me. NASA's countermeasures research established what the Chinese practice had encoded empirically: impact loading, not merely resistance exercise, is required to maintain bone density. Resistance exercise produces static force without the dynamic shock wave that triggers the full mechanotransduction response. Pulling against a band loads the muscle. Dropping onto the heels loads the bone. The distinction matters Because the mechanical signal requires deformation, rapid, transient compression that deforms the crystal lattice and generates the charge. Static loading does not produce the transient deformation. Impact does. The multi-billion-dollar problem of bone loss in space. The single largest physiological barrier to long-duration spaceflight is produced by the absence of the signal that a 70-year-old generates by dropping onto their heels in a kitchen. The signal is free. The signal is gravity. You see? And the skeleton is only one system. The heel drop activates. Because the impact travels through bone, but the movement involves muscle, tendon, lymph, and the vestibular system, each responding to the drop through a different mechanism, each receiving a signal the sitting body does not provide. Calf muscle pump, described in the sitting discussion, is the gastrocnemius and soleus compressing the deep veins of the lower leg with each contraction, pushing blood upward through one-way venous valves against gravity. The pump is powerful. Each full contraction generates enough pressure to propel a bolus of venous blood upward through the valves and into the popliteal vein behind the knee. During walking, the pump cycles with each step. During sitting, the pump is inactive. The calf muscles are relaxed. The veins are uncompressed. The blood pools under gravity. During heel drops, both calf muscles contract forcefully to raise the body onto the toes. Gastrocnemius and soleus engaging simultaneously under the full load of body weight. Then release as the heels drop. Each cycle is a complete contraction release of the pump. 30 heel drops is 30 pump cycles. 30 boluses of venous blood return to the heart from the lower legs in 60 seconds. Venous pooling that sitting produces, blood accumulating in the lower leg veins, venous pressure rising, fluid leaking into interstitial tissue producing the ankle swelling you recognize by evening, is partially reversed by each pump cycle. The person over 65 who has swollen ankles by 4 in the afternoon has a calf muscle pump that has been inactive for hours. The veins are distended, the fluid has leaked, the pressure has built. 30 heel drops reactivates the pump, the venous blood returns, the pressure normalizes, the swelling decreases, not through medication, not through elevation, through the mechanical pump, the body built into the calf and that sitting switched off. Well, and the lymphatic system. Because your lymphatic system has a problem. Your cardiovascular system does not. It has no heart. Your lymphatic system, the network of vessels that drains interstitial fluid, transports immune cells, and filters metabolic waste, depends entirely on external forces to move lymph. Unlike the cardiovascular system, which has the heart generating continuous pressure, the lymphatic system has no central pump. Lymph moves through muscle contraction, compressing the lymphatic vessels, respiratory pressure changes during breathing, and gravitational shifts during movement. Lymphatic vessels contain one-way valves, identical in principle to venous valves, that allow fluid to move only toward the thoracic duct for return to the bloodstream. Rhythmic muscle contraction and release. The exact pattern of heel drops is the primary mechanical driver of lymphatic flow in the lower limbs. Each calf contraction compresses the lymphatic vessels, pushing lymph upward through the valves. Each release allows the vessels to refill from the interstitial space, drawing in the fluid, the immune cells, and the waste products that accumulated between contractions. 30 heel drops is 30 compression release cycles across the lymphatic network of both legs. 30 pulses driving lymph toward the inguinal lymph nodes for immune processing and waste filtration. Person who has been sitting for 3 hours has a lymphatic system in the lower limbs that has been nearly stagnant for 3 hours. The immune cells that patrol the interstitial space are pooled, concentrated in the fluid that is not moving, unable to reach the lymph nodes where they present antigens and initiate immune responses. The metabolic waste products that cells excrete into the interstitial fluid are accumulating. The concentration gradients that drive waste removal have flattened because the fluid carrying the waste is not being replaced. The interstitial fluid itself is building. The volume increases because the lymphatic drainage that normally removes it has slowed to a fraction of its active rate. 30 heel drops in 60 seconds mobilizes what 3 hours of sitting allowed to accumulate. The lymphatic flow rate increases. The immune cells begin moving toward the nodes. The waste products dilute as fresh fluid enters the interstitial space. The volume decreases as the drainage resumes. The system was designed for a body that moved continuously throughout the day, walking, bending, climbing, squatting, lifting. The modern body sits for hours. The heel drop is the minimum mechanical intervention that reactivates the lymphatic flow the sitting eliminated. 30 compression release cycles delivered in 60 seconds, requiring nothing but a floor and the body weight that provides the force. And then the vestibular system. Because each heel drop produces a brief, sharp vertical deceleration that the inner ear detects and the cerebellum processes as a calibration event. And the calibration is what prevents the falls that concern adults over 65 most. Each drop, the moment the heels strike the ground after the controlled fall from toes, produces a transient vertical deceleration of approximately 2 to 3 G. The otolith organs in the inner ear, the utricular and saccular maculae, the gravity-sensing structures that tell the brain which way is down, detect this deceleration as a sharp, brief change in the gravitational signal. The cerebellum receives the data and uses it to refine its model of vertical orientation, gravitational force, and the postural adjustments required to maintain balance during rapid vertical changes. 30 heel drops is 30 vestibular calibration events. 30 data points the cerebellum uses to maintain the accuracy of its gravitational model and the speed of its postural correction algorithms. The balance degradation that the foot discussion documented, the progressive loss of vestibular cerebellar calibration that predicts falls and correlates with mortality in adults over 65, is driven partly by the absence of variable gravitational input. Sitting provides zero vestibular variation. The otolith organs report an unchanging gravitational signal hour after hour. Walking provides low amplitude cyclic variation, a gentle oscillation that maintains basic calibration but does not challenge the system's processing speed. Heel drops provide high amplitude transient variation, a sharp, sudden deceleration signal that demands rapid cerebellar computation, the kind of rapid computation the balance system must perform during a stumble or a trip. A person who practices heel drops daily is training the vestibular system for the exact scenario that causes the falls the person fears. A stumble produces a rapid, unexpected change in gravitational loading. The foot catches, the body lurches, the otolith organs fire a transient signal. The cerebellum must process in milliseconds to generate the corrective postural response that prevents the fall. A cerebellum that processes 30 high-amplitude transient signals every morning is faster and more accurate in its correction than a cerebellum that receives only the low-amplitude signals of level ground walking. The training is specific to the demand. The demand is rapid balance correction. The training stimulus is the heel drop. Consider the Achilles tendon. Because the largest tendon in the body depends on this cycle to maintain itself, and the consequences of its failure are immediate and severe for the person over 65. Achilles tendon stores and releases elastic energy during the heel drop cycle the way a spring stores, and releases mechanical energy during compression and extension. Rising onto the toe stretches the tendon, loading it with potential energy. The collagen fibers elongate under tension, storing mechanical energy. Dropping onto the heels releases the stored energy as the tendon recoils to its resting length. This stretch recoil cycle is not merely using the tendon. It is maintaining the tendon. The cyclic loading stimulates the tendon's fibroblasts to produce new collagen, to remodel the existing matrix, to maintain the fiber alignment that gives the tendon its elasticity and its strength. Tendon stiffness increases with age as collagen cross-links accumulate. The glycation, the entropy discussion described as an entropy accelerating process, the non-enzymatic binding of glucose to protein that produces permanent molecular bridges between adjacent collagen fibers. The cross-links bind the fibers together. The fibers lose their ability to slide past each other. The tendon loses elasticity and gains brittleness, the mechanical equivalent of a rubber band that has dried out and cracked. The Achilles tendon that is never loaded through its full stretch, recoil range becomes progressively stiffer, progressively more brittle, and progressively more susceptible to the rupture that is among the most debilitating injuries an older adult can sustain. Because a ruptured Achilles eliminates the push-off phase of walking, eliminates the ability to climb stairs, eliminates the ability to rise from a seated position without using the arms, and requires months of immobilization that produces the bone loss, the muscle atrophy, and the cardiovascular deconditioning that the heel drop is preventing. 30 heel drops per day is a maintenance protocol for the tendon that connects your calf muscle to your ability to walk. The stretch recoil cycle provides the mechanical signal the fibroblasts require to maintain collagen turnover. The collagen turnover replaces the cross-linked, brittle fibers with new, elastic fibers. The tendon maintains its compliance. The compliance prevents the rupture. The prevention costs 60 seconds per day. And here, the calcaneal fat pad. Because the body's primary impact absorber sits directly beneath the bone that receives the first contact of every heel drop, and the tissue degrades with exactly the kind of disuse the indoor world imposes. Heel pad, a specialized structure of adipose tissue chambers separated by fibrous septa beneath the calcaneus, is the body's shock absorber for heel strike. The structure is not ordinary fat. It is engineering. Closed chambers of adipose tissue enclosed by tough fibrous walls that distribute the impact force across the entire calcaneal surface rather than allowing it to concentrate at a point. When the heel strikes the ground, the chambers compress, the walls flex, and the kinetic energy of the impact is absorbed and dissipated as heat across the entire pad rather than transmitted as a shock wave directly into the calcaneus. With age, the fat pad thins and the septa weaken. The chambers lose volume. The walls lose integrity. The shock absorption capacity decreases, and the force transmitted through the calcaneus to the ankle, knee, and hip above increases. The thinning is partly age-related collagen degradation. The septa are collagen structures subject to the glycation and cross-linking the entropy discussion described. It is also partly use-dependent. The fat pad, like bone, like tendon, like muscle, maintains itself in response to the mechanical demands placed upon it. A fat pad that receives regular controlled impact maintains its chamber volume and septal integrity because the fibroblasts that maintain the septa receive the mechanical signal to continue producing collagen. A fat pad that receives only the low impact forces of indoor walking on flat surfaces, forces below the threshold that stimulate septal remodeling, thins because the maintenance signal is insufficient. Person over 65 who complains of heel pain when walking on hard surfaces, who avoids concrete, who wears thick-soled cushioned shoes, who limits walking distance because the heels hurt, may have a fat pad that is thinned from decades of insufficient impact loading. The cushioned shoes that were supposed to protect the heel may have contributed to the thinning. By absorbing the impact before it reached the fat pad, they removed the mechanical stimulus the fat pad required to maintain itself. The protection caused the degradation it was protecting against. The same paradox the dirt walking discussion described for the foot's proprioceptors. The shoe that cushions the heel deprives the heel of the signal it needs to maintain its own cushion. Heel drops provide controlled impact directly to the fat pad, training it to absorb force at a magnitude the person controls. Begin gently, low toe raise height, 2 to 3 centimeters, a soft landing that the fat pad absorbs without discomfort. Progress over weeks to sharper drops from full toe. Raise height, 5 to 8 centimeters, as the fat pad and surrounding tissues adapt to the increased load. The graduation is important for the person whose fat pad is thinned from years of low-impact living. The tissue needs time to remodel. The remodeling occurs in response to progressive loading. The hormetic principle applied to the shock-absorbing tissue beneath the heel. The pad rebuilds. The shock absorption improves. The force transmitted to the joints above decreases as the natural cushion restores itself. That convergence, mechanical bone signaling through every vertebra in the axial skeleton, venous return through the calf pump, lymphatic mobilization through rhythmic compression, vestibular calibration through transient deceleration, tendon maintenance through stretch recoil cycling, and fat pad preservation through controlled impact loading, is the finding that made a 60-second morning practice feel like it contained the maintenance schedule for the entire lower body. 6 systems, 30 repetitions, 60 seconds. Every system receiving the signal it requires to maintain itself. Signals that sitting withholds, that indoor living on flat surfaces eliminates, that the modern sedentary day fails to provide across hours of stillness. No other single movement activates all 6 simultaneously. Walking activates the calf pump and produces low-level mechanical signaling, but does not deliver the high-amplitude impact that drives the strongest osteoblast response. Running delivers the impact, but is inaccessible to most adults over 65. Cycling activates the calf muscles, but produces no axial impact. Swimming eliminates gravitational loading entirely. The heel drop is the only movement that delivers high-amplitude axial impact. Full calf pump cycling, lymphatic compression release, vestibular calibration, tendon stretch, recoil, and fat pad loading in a single repetitive action that requires no equipment, no cardiovascular fitness, no balance confidence beyond the ability to stand, and no time beyond 60 seconds. One note before the protocol. Because the population over 65 includes people with conditions where impact loading requires caution, the movement is contraindicated for anyone with active joint inflammation, acute fracture risk, or conditions where impact is medically restricted. A person with diagnosed severe osteoporosis, active knee or hip pathology, vertebral compression fractures, or uncontrolled balance disorders should consult their physician before adding impact loading. For most adults over 65, without these conditions, the progressive approach, beginning at low drop height and increasing over weeks, allows the tissues to adapt safely. Stand barefoot or in thin-soled shoes on a firm surface. Not carpet, not a foam mat, not anything that absorbs the impact before it reaches the skeleton. The impact is the signal. Absorbing it defeats the purpose. A kitchen floor, a patio, a concrete path, any surface that transmits the shock wave through the heel into the calcaneus and up through the axial skeleton. Rise onto your toes. A controlled, moderate height rise, not a maximum stretch. 2 to 3 centimeters is sufficient for the first week. The rise loads the Achilles tendon with elastic energy and contracts the calf muscles that will power the venous and lymphatic pump cycles. Pause for 1 second at the top. The pause ensures the rise is controlled rather than bounced and allows the full calf contraction to compress the venous and lymphatic vessels before the release. Drop onto your heels. Allow gravity to bring you down. Do not lower yourself slowly. Do not cushion the landing with your knees. The impact should be felt through the heels, the ankles, the knees, the hips, and the spine. That feeling is the shock wave traveling the axial skeleton. That shock wave is the mechanical signal arriving at every osteocyte along the vertical axis. If the impact produces discomfort in the knees or the lower back, reduce the drop height. The signal still arrives at a lower magnitude, and the tissues will adapt over weeks to tolerate progressive increases. Repeat 30 times. 60 seconds. In those 60 seconds, every bone in your vertical axis has received 30 mechanical signals directing osteoblasts to maintain mineral density along the lines of compressive force. Your calf muscle pump has cycled 30 times, returning pooled venous blood from the lower legs to the heart and reducing the venous pressure that produces ankle swelling. Your lymphatic system has received 30 compression release cycles, mobilizing the immune cells and waste products that sitting allowed to stagnate in the interstitial fluid of both legs. Your vestibular system has processed 30 high-amplitude calibration events, refining the cerebellar model that computes the postural corrections that prevent falls. Your Achilles tendon has completed 30 stretch recoil cycles, maintaining the collagen elasticity that prevents the brittleness and rupture that immobility produces. Your calcaneal fat pad has absorbed 30 controlled impacts, maintaining the chamber volume and septal integrity that cushion every heel strike of every step you take. 6 systems, 30 repetitions, 60 seconds. Standing in your kitchen. Every morning in parks across China, adults over 60 already know this. Not the bone mechanotransduction data, not the NASA research, not the lymphatic physiology, not the vestibular calibration literature. They know it because their bodies told them what the research confirmed later. The impact feels right. The skeleton responds. The legs feel lighter. The morning starts differently. Their grandparents did it. Their parents did it. They do it. The practice survived because the bodies that practiced it functioned better than the bodies that did not. And the difference was observable across decades of aging, across communities, across generations. When medical intervention is needed, it is needed. Osteoporosis that has progressed to fracture risk requires pharmacological management. Venous insufficiency that has produced ulceration requires clinical treatment. Severe balance disorders require supervised rehabilitation. The heel drop is not a replacement for any of these. It is what the medical system does not provide. The daily mechanical input that maintains the 6 systems before they degrade to the point where medical intervention becomes necessary. Western medicine approaches these 6 systems through 6 separate interventions when they fail. Bisphosphonates for bone density, compression stockings for venous insufficiency, manual lymphatic drainage for edema, balance training programs on foam pads and wobble boards, physical therapy for Achilles tendinopathy, cushioned orthotics for heel pad atrophy. 6 specialists, 6 appointments, 6 interventions, each addressing one system in isolation, each treating pathology that has already developed. The Chinese practice addresses all 6 through prevention. 60 seconds of impact loading that provides the mechanical signals every system requires to maintain itself, delivered simultaneously every morning standing in a kitchen. And the bones that carry them, the bones that Western medicine measures with DEXA scans and treats with bisphosphonates when the numbers cross a threshold, are receiving the signal those bones were designed to receive. 30 drops, 60 seconds. The shock wave travels from your heels to your skull, and every bone along the way receives the only signal it understands. The signal that says, build, maintain, stay dense, stay strong, stay upright. Your kitchen floor is the park. Your heels are the equipment. Gravity does the rest.